Canal. Hello and welcome everyone to tonight's webinar on relative energy deficiency in sport. This webinar is brought to you by Capital Health Network and Dr. Karen Bisley from Sports Physicians ACT. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. I pay my respects to their elders past, present and emerging. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and has never been ceded. I am Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is Dr. Karen Bisley and Kanal Mohiti, the Events Lead at Capital Health Network. So onto the routine part of the night, which is the housekeeping. All participants have been muted. Please address any questions in the Q&A section of your Zoom screen, not in the chat box. So the Q&A box, not the chat box. We will have a question and answer session after Karen has finished her presentation. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks. Regarding CPD, please fill in the post-event evaluation survey. CHN will email you a certificate of attendance after the event, and please feel free to self-report 1.5 hours of educational activities to your CPD home. So our speaker tonight is Dr. Karen Bisley, and Karen wears many hats and loves a challenge. She's a sports and exercise physician and a general practitioner. Prior to medical school, she was a radiographer. The combination provides her with a wide range of expertise when treating patients. Karen also has a master's in health science. Her dissertation was on the use of skin fold measurements to predict outcome in open water swim attempts in the Cook Strait in New Zealand, and that you'll see why that's important for her in a second. She's looked after the New Zealand School of Dance when she lived in Wellington and developed an ongoing interest in dancers and gymnasts. Karen practices at Sports Physician ACT, located in Deakin in Canberra, and she's currently looking after the Brumbies women's team. She's been the match day and medical room doctor for the Brumbies home games for many years, and that involves observing and monitoring for concussion. She has been the medical tent lead doctor at the Canberra Marathon for many years, and she's travelled with the Australian Paralympic swimmers and the Australian croquet team. She's currently involved in the New Zealand Ice Swimming Championships, thus skin fold measurements, and is an International Ice Swimming Association medical committee. And she was just telling me before we started she's about to go to Queenstown and swim in a swimming pool there where the water temperature. Oh, you're not swimming. Okay,
I'm not swimming.
You're watching other people swim in water that's less than 5 degrees. And she herself is an open water swimmer, and her accomplishments include at the age of 16 years old, swimming the Cook Strait, a 23 to 26 kilometre rough water swim from the south to the North Island of New Zealand. And 2 years later, she did the 40-kilometre Lake Taupo swim at a cracking pace of 4 kilometres an hour. I've been on the Cook Strait, and I can tell you it's very rough, and sometimes the waves go over the top of the ferry, so it'd have to be a calm day, I imagine. There's even an open water Wikipedia page celebrating her accomplishments. So in her spare time that she's got any, she plays croquet, and she's currently in the New South Wales croquet squad and is the Chief Medical Officer for Croquet Australia. So over to you, Karen. No pressure.
Okay, thank you. So as Leonie said, today I'm talking about REDS, or relative energy deficiency of sport. And it's a complex topic. Well, it's very simple when you start getting into it, but I think I'll try and sort of explain it as we go. And I just sort of start with the background rather than anything else. And this says past attitudes of coaches and teams, but there's still quite a lot of attitude sort of towards teams and things. And the focus has always been about athletes winning, and rather than necessarily always thinking about the health of the athlete. So there's often been thoughts of like concepts of the skinnier the better, and looking at the appearances of athletes, and even look at the volleyballers there. It's about what they wear, and there's sort of internal external pressures on the athletes to look good. And I'll just quote Barbara Drinkwater: whenever the desire to win is stronger than anything else, we will have problems with sacrificing the well-being of the athlete, whether it's male or female. So just to give a history of what I'm doing today, I'm going to talk about the history of REDS. I'll talk about the female athlete triad and now REDS, some of the conceptual models, the systems involved, and I'll also talk about the similarity to overtraining syndrome. I'll talk about a few of the screening tools available, particularly the IOC REDS CAT2 and investigations and treatments. What I've done here is these are some of the references I've used. So what I've done, because it gets really complex, I've actually put them in different colors. So, and if you want to go back later, you can. So blue is basically just indicating some of the bits and pieces that I've talked about, and you'll see that they're highlighted in blue, similarly with red and the orangey color. So it'll just give it a bit of an idea of where the information comes from, rather than trying to sort of highlight it and say this is where it's from throughout this talk. So I've talked about the IOC, I showed you the IOC ones, and this is also the AIS, disordered eating and high performance sport position statement. So there's a few areas that I've brought the information from. So to start with, I'm going to talk about the history of REDS. So Barbara Drinkwater, who I just quoted before, she's really probably one of the forerunners of the female athlete triad. She was the person who set the stage of the triad, and she demonstrated the link between bone mineral density, menstrual status, and change of bone mineral density after resumption of menses. And I'll talk about her a little bit more later. So the female athlete triad was first described, surprise, surprise, by Dr. Drinkwater in 1992. So we realized she mentioned that it was 3 distinct entities. So you had the disordered eating, the amenorrhea, and the osteoporosis. And I'll just sort of skim over some of these things because it sort of gets repetitive, but I'll just give you a background of where things are from. So jump to 1997, and the ACSM put out their first position statement on the female athlete triad. Again, saying that the pressure to achieve or maintain unrealistic low body weight underlies the development of the triad. Females were at greatest risk, and it was advised that if one component of the triad was present, we should always screen for the other components. The problem is the female athlete triad alone can be it can be in a combination. It causes decreased physical performance, and it can go on and cause morbidity and mortality, which we'll get into a bit later. So jump to 2005 now, and this is really a stylized picture of the female athlete triad. And at this stage, we're still talking about disordered eating, amenorrhea, and osteoporosis. Just amenorrhea was a bit more expanded to irregular periods, secondary to decreased endogenous estrogen. So I'm just mentioning, so often there's no overt signs of energy deficiency other than irregular or absent menses. And there's also the risk that some athletes will slip from a disordered eating into eating disorders. So I'm jumping up to the American College of Sports Medicine's position stand, and this is cool. Well, this is where we first went to the female athlete triad. So they redefined it, and so instead of disordered eating, they've talked about energy availability. So it's become, the problem is actually lack of energy available rather than actually disordered eating. The concept that over a period of time, an athlete can actually move from one continuous end of a spectrum to another. So it may be during their time as training, or it may be over their lifetime, but they can be in the optimal period, or they may be in a suboptimal area. And I'll talk about this in a second. So this is in 2014, and this is another study, but I really like this picture. And the simple reason is it shows sort of the optimal, what we want is amenorrhea, good bone health, and optimal energy, and that's all down the green end. And the red end, which is not so good, the low energy availability, the functional hypothalamic amenorrhea, and the osteoporosis. And then you can be anywhere between those two zones as well. So we'll jump to 2014, and this is the first IOC consensus statement, and it's called, and they focused beyond the female athlete triad, so which is relative energy deficiency in sport. So they've basically identified it as a syndrome, and it's males and females are both at risk of this problem. So the important thing is it's not a female athlete triad, because males are affected as well, and it's a syndrome because it affects lots of the physiological function as well as the health and athletic performance. And psychological issues, they can precede RED-S, but they can also be the result of RED-S. So this is a conceptual model that they put forward, and it looks a little bit busy, but I think what you can see is the red triangle, and that was really where the female athlete triad came in. So it's indicating the menstrual function, bone health, and disordered eating, and that's only one small component of all the different physiological things that can be involved. And I'll talk through these in a little bit more detail in a minute. So this is a little bit of a busy slide indicating what is RED-S. And I'm just going to jump past this, and I've just summarized it slightly. So RED-S is a syndrome of physiological and psychological functioning affecting both male and female. The cause is by exposure to problematic low energy availability, and it has detrimental outcomes to multiple systems. It affects energy metabolism, reproductive function, musculoskeletal health, immunity, glycogen synthesis, cardiovascular, and hematological health. And any of those can lead on to impaired well-being, increased risk of injury, and decreased sports performance. So this is just a little formula, and I'm not going to get too much into that, but low energy availability is a mismatch between the energy intake and the energy expenditure, leaving the body's total energy needs unmet. So I've talked briefly that athletes are driven by both internal pressures to succeed and external pressures of others to live up to expectations, etc. The problem is energy deficiency can be intentional, so that people are deliberately restricting themselves so that they make weight, etc. But many of the people are actually unintentional. And these are the people like the marathon runners, cyclists, where essentially they're just doing so much energy, they're burning up so much energy, they're just not eating enough to replete the energy they've expended. So there's a couple of just numbers here, and I won't make it too much detail. So the universal cutoff at the moment for the threshold of RED-S is in females is 30 kilocalories per kilo of fat-free mass per day. In males, it's about 9 to 25 kilocalories per kilo per fat-free mass per day. So as you can see, the males are a lot lower. They're also less well understood. And in the studies between 2018 to 2022, only 20% of those studies involved males. We understand that males can sustain a lower energy availability, and we now know problematic low energy availability is the underlying problem, which is affecting the hypothalamic pituitary gonadal axis, and so there's changes in the metabolism, immune function, bone health, etc. What we don't understand is exactly who gets it and when they get it, because the magnitude and threshold effects are variable between the genders. So I'm just going to give you a scenario, and I'm not going to talk about it, but I'll talk about this person a little bit later. So this is a 17-year-old dancer. They presented, they have primary amenorrhea. They have developed secondary sexual characteristics, but they've had a history of a stress fracture. A year earlier, they had a 5th metatarsal fracture, and 18 months before that, they had a cuboid stress fracture, and they also have a history of depression. So there's a lot going on with this person, and at a later stage, I'm going to go through and discuss it a bit more, but I just want to bring up the sort of thought process at this stage. So we briefly talked about the conceptual model, and I'm just going to go through some of these things at this point in time. So we know endocrine effects are important, and obviously in some female athletes in low energy availability states. The problem is it's hard to measure low energy availability unless you're actually measuring every single piece of food that's going into somebody's mouth and actually doing their energy expenditure as well. But we do know that athletes with amenorrhea or altered menstrual function, they've got a good indication that essentially there's a low energy availability state. There's so many changes. There's changes in thyroid function, the appetite regulating hormones. There's decreases in insulin and insulin growth factor, and increases in growth hormone resistance and elevations in cortisol. So the hormonal changes, they are generally thought to be to conserve the energy or to use the body's energy reserves for the vital processes. So I'll just jump on. So in men, REDS is also present, and it's again a low energy availability problem. The problem is men aren't as easy to pick up, but potential indicators in men include a low libido or decreased morning erections. So often with men, it's sport specific. So it's an activity such as making weight, such as like body mass composition. So people like jockeys, bodybuilders, and it's also, as I've mentioned before, it can be to do with prolonged low energy intake and high energy expenditure, such as the rowers, the cyclists, and the runners. There can also be cultural factors. So people are not eating, they're fasting, and sometimes it's down to financial insecurity where they don't actually have enough money to go and buy decent food. In men, low serum testosterone is an indicator, particularly in the lowest quartile. So I won't get too much into these, but there's a few little articles. In male marathon runners, there's been shown to be a high association with low energy availability, and there's been shown to be a low luteinizing hormone pulsatility and amplitude. There's also been shown to be decreased testosterone and inconsistent findings of differences of basal luteinizing hormone parameters. So the effects of low energy availability on reproductive hormones and menstrual function. So it's thought to be to do with disruption of the gonadal releasing hormone pulsatility on the hypothalamus, causing alterations in luteinizing hormone and FSH release and decrease estrogen and progesterone levels. So the duration and severity of LEA causing the disturbances is unclear. The frequency of menstrual disturbances has been shown to be affected by the energy deficit, and a specific threshold I've mentioned is below which menstrual disturbances have occurred has not been exactly identified. So some of the definitions here, and I won't spend too much time on it because most people should know, but eumenorrhea is between 21 to 35 days for a normal person, as opposed to an adolescent, which is 21 to 45 days. primary amenorrhea, no menarche by age 15. Secondary amenorrhea, absence of 3 consecutive cycles, and oligomenorrhea greater than 45 days. So the problem is menstrual dysfunction can be a surrogate for low energy availability, but it gives us an idea, but it doesn't determine that it's going to be everybody's going to end up with menstrual dysfunction. So this is just another article that I pulled up, is that amenorrhea has been shown it can occur in 66% of athletes. And the important thing is if somebody presents with amenorrhea, don't accept that it's normal just because they're an athlete. So if it's been greater than 3 months, perhaps we should be starting investigating. We've still got, people are still normal. They can have pregnancy and they can have a number of other medical conditions which can make them prone to amenorrhea, which is not functional hypothalamic amenorrhea. This is a diagnosis of exclusion rather than the norm. So the important thing is the cause of functional hypothalamic amenorrhea is actually not low energy availability. It is low energy availability. It is not too much exercise. So ideally, you get a sports nutritionist or dietitian in early to try and optimize health and intake. So if I see somebody, I think the ideal is the sports dietitian as first line. The next problem is contraception. Obviously, some people are sexually active and they need protection. And obviously, if somebody is amenorrheic, they are less likely to get pregnant. But as you increase their energy intake, potentially they're at risk of getting pregnant as their menstrual cycles start before they have their first period. The problem is treatment of menstrual dysfunction does not help using the oral contraceptive pill. It doesn't correct the functional hypothalamic amenorrhea, and it doesn't correct the bone mineral density loss. But it can, so to protect the bone mineral density, it's recommended, and trying to get this stuff at the moment is a nightmare, it's recommended that something like transdermal estrogen with oral progestogen as an adjunct is worth considering in patients. Obviously, if they're on the pill for contraception, a different story, but if they're not sexually active, I actually try not to put them on the pill. And the simple reason is that I can actually monitor when their periods start again, if they do. And otherwise, if they're on the pill, I really have no idea where they are at. This is just another article. So just the prevalence of secondary amenorrhea in collegiate women, it can be 2 to 5%. In dancers, it can be up to 69%, and long distance runners, 65%. In primary amenorrhea, again, collegiate athletes may be 7%, and other athletes can start getting higher numbers as well. And I think what we're starting to realize is that subtle menstrual dysfunction is probably underestimated. We just accept very light bleeding as potentially normal, mildly extended bleeding as normal, premenstrual or postmenstrual spotting as normal. But all of these may actually be part of REDS and low energy availability. So I'm going to talk about bone health now. And sorry, I'll just get through a couple of topics and then we'll get on to some more interesting stuff. So we know that low energy availability contributes to impaired bone health in athletes. So there's been cross-sectional studies of physically active females with oligomenorrhea and amenorrhea, and they've shown decreased bone mineral density, altered bone architecture, altered bone turnover markers, decreases estimates of bone strength, and increased risk of bone stress fractures compared to eumenorrheic athletes. Short-term low energy availability via diet and exercise has been shown to negatively affect bone turnover in males and females, and we've already talked about specific populations. in athletes, anatomical sites where anatomical sites where bone loading is greater. And sorry, I just can't actually see my slide. I might just see if I can change it. Okay, that's better. Anatomical sites where there's less bone loading are at greater risk of trabecular bone. So the lumbar spine and the radius compared to cortical bone, such as the total hip. So BMI is actually a very poor surrogate marker for measuring bone health. There's proposed indicators such as a BMI less than 17.5, less than 85% of the expected body weight, or greater than 10% loss in 1 month. And low energy availability, as we've mentioned, can be associated with disordered eating and eating disorders. So the combination of the factors basically puts the athletes at higher risk of bone stress injuries. So this is the study from Drinkwater, and she observed in amenorrheic athletes who were found to have lower vertebral bone mineral density. Their athletes, when they regained their menses, also showed improvement of their vertebral bone mineral density. So I'm just going to run through some patients that have sort of run through my practice in the sort of last couple of years. This is a 22-year-old female distance runner who presented with low back pain. She had increased her training load quite a bit over the recent months, and as she presented with right low back pain. And I think it's pretty obvious that she's got a sacral stress fracture. The next one was a 40-year-old male. He had increased his running only about for 10 days. He had always run on flat, undulating surface, and he decided to increase his load and start doing a lot of stairs. And that wide area is just showing the stress reaction in his tibia. The next one was a 20-year-old male distance runner. He presented with non-specific pain in his navicular, and you can see a stress fracture of the navicular. So just before I continue, I think you can see all of those people we've just talked about were all distance runners, and were all doing a lot of training. So I suspect that was the underlying predisposing factor, not necessarily obvious energy deficiency, but they were really doing a lot of activity and probably not eating enough. So I'll briefly talk about the metabolic changes. So there's been a correlation between low energy availability and decreased resting metabolic rate. With increased training load while maintaining the constant energy intake over a 4-week period in male and female elite rowers, this also demonstrated a significant reduction in resting metabolic rate. And the last study, athletes were who had severe energy deficient demonstrated changes decreased in their leptin, T3, IG1, IGF-1, and increases in ghrelin. So there's also hematological factors. So we know iron is essential for hemopoiesis and oxygen carrying capacity. So iron deficiency can both directly and indirectly cause energy deficiency. It can be due to decreased appetite, decreased metabolic fuel availability, and impaired metabolic efficacy, leading to increased energy expenditure during rest and exercise. So iron deficiency may interact with with bone, causing dysregulation of the growth hormone IGF axis, hypoxia, and hypothyroidism. In addition, iron plays an important role in thyroid function, fertility, and psychological well-being. So low energy availability may be partially induced by and contribute to iron deficiency. So other surrogates of low energy availability have been correlated with hematological dysfunction, low ferritin, and iron deficiency in adolescents and young females. There's also cardiovascular changes. So it's been shown that there's early atherosclerosis, which may occur in athletes with hypoestrogenism and functional hypothalamic amenorrhea. Endothelial dysfunction and unfavorable lipid profiles have been seen in amenorrheic athletes, with the resumption of menses leading to improvements of vascular endothelial function. So in one study of amenorrheic athletes, it showed that lower heart rate and systolic blood pressure compared to eumenorrheic athletes, and disruptions of the normal renin-angiotensin-aldosterone response. In the severe form of energy deficiency, such as anorexia nervosa, you can get significant cardiovascular changes, such as valve abnormalities, pericardial effusions, severe bradycardia, hypotension, and arrhythmias. So growth and development can also be affected. So linear growth can be a linear growth retardation. This is seen in both males and females with severe anorexia nervosa. So they may or may not completely ever catch up to their anticipated growth. So there's various hormonal changes in anorexia and also amenorrhea. There's a lot of research that still needs to go on in this region. There's also gastrointestinal changes. So in the severe case again of anorexia nervosa, you can get negative health influences on the GI tract, such as altered sphincter function, delayed gastric emptying, constipation, and increased intestinal transit time. So there's a questionnaire we use, which is low energy availability among female athlete questionnaire. It's called the LEAF-Q, and we've this is used to sort of pick up some of the GI effects and some of the effects of relative energy deficiency in sport. And I'll talk about this questionnaire a little bit later. There's also immunological functions. And this is a study of 21 Japanese elite collegiate runners, and they reported more upper respiratory tract symptoms and lower IgA secretion rates in the amenorrheic athletes. There was an observational study in Australian athletes prior to the Rio Games. They measured the LEAF-Q in the female athletes and noted that they were increased likely to get upper respiratory tract and GI symptoms. There's also psychological indicators for problematic low energy availability. You get mood disturbances, dietary restraints. People are driving to become thin. It affects their sleep. They become perfectionist. There's depressive symptoms and affective disorders, and subjective reduced well-being. So you've got so many things, such as anxiety, related to having time off if they can't exercise. They have difficulty coping with weight measurements, and then there's the risk of development of eating disorders and their perceived stress. So the mental health of athletes has to be the priority, and there's becoming more and more consensus statements being placed at the moment indicating that mental health is the priority. So it's become increasingly aware, and it's just something we need to think about in every athlete we see. So we've talked about the intentional and also the unintentional causes of low energy availability. The problem is that intentional short-term can have positive effects. So if you lose some weight, you may do really well, and that can sometimes be a negative problem, because then you think, I should start losing weight to perform. But unfortunately, with long-term, it is a negative problem. It is a problem. So performance consequences of low energy availability. So there's lots of surrogates of low energy availability, which I've talked about, and the negatively influence on illness, injury, iron deficiency, and impaired cognition and mood. And we've postulated that persistent low energy availability can impair sport via a number of mechanisms, such as impaired recovery, premature reduction in physical psychological, mental capacity, and impaired optimal muscle mass and function. So I've talked a lot. So this is just another sort of example. And so this time it's basically looking at all the symptoms that can occur secondary to REDS. And I'm not going to go through it, but you can see here, there's things like decreased endurance performance, increased injury risk, decreased training response, impaired judgment, decreased coordination, decreased concentration, irritability, depression, and decreased glycogen stores, and decreased muscle strength. Which I think most of this I've already covered. So the important thing is striving for greater power mass ratio is regarded as important for running performance. But the problem is severe and persistent low energy restriction causes the negative effects, affects performance and health. So an IOC consensus statement on REDS in 2018, they showed with optimal energy availability, this is not low energy availability, the optimal is 45 kilocalories per fat-free mass per day. So I'm jumping to 2023 now, the IOC most recent statement. And since their previous one in 2018, there's been over 170 original papers on REDS. There's emerging data demonstrating the role of low carbohydrate availability with low energy availability. There's greater numbers showing that problematic low energy availability is the underlying cause. So I'll talk about problematic versus adaptable low energy availability in a minute. So there's also further evidence for interplay between mental health and REDS, and there's more and more data coming out on males. Now, I'm just going to briefly mention low carbohydrate availability. So most low energy availability intervention studies have shown that's a reduction in carbohydrate as well, sometimes between 25 to 60% decrease in carbs. In the world, the magnitude of low carbohydrate is probably even higher because at the moment there's an emphasis on high protein intake and intake high protein, and the more protein we're taking in, the less carbohydrate we're probably taking in too. So recent studies have shown there's a deleterious effect of bone immunity and iron markers as a result of the low carbohydrate availability, sometimes even in the absence of low energy availability. So there's 6 studies have been shown that energy independent and or magnifying impact of low carbohydrate availability is accelerated, causing development of REDS. So there's still lots of studies to be done. Now I'm just going to present this 21-year-old male, well known to me. He cycles to and from work. He probably did 20 kilometers per week and almost 20 kilometers per day. And one day he caught the bus home. It was a wet day. And instead of walking like most people, he ran down the hill crazily. And he developed knee pain. And I think you can see just there's a small area of increased bone stress, and there's a little stress injury on the condyle of the femur. Interesting enough, he eats very healthy. So he tells me he's been avoiding sugar from his diet completely. So he has been looking at everything, trying to avoid all sugar. And interestingly enough, there's a condition called orthorexia. Ortho meaning to correct, and orexis, appetite. A person with orthorexia is fixated with the quality rather than quantity of their food to an excessive degree. And my suspicion is that this guy probably had a bit of orthorexia. He cut his carbohydrate completely out, or as much as he could, and potentially had carbohydrate deprived himself. I'll probably never be able to prove it, but that's my suspicion. So jump back to 2023 IOC consensus statement. So at this point, they've introduced health and performance conceptual models, physiological models. They've talked about problematic and adaptable low energy availability, and they've now outlined some guidelines of safe and effective body composition assessment. And they've introduced the REDS clinical assessment too. And I'll talk about some of these things now. So just back to 2018, the health conceptual model is to the left, and you can see that all the circles are coming out from the side, and you can see where the female athlete triad. So now in 2023, the conceptual model has changed. So you can see low energy availability in the center. You've got arrows pointing outwards towards the periphery. So in the middle of the circle, the white arrows, basically they're indicating the sort of the low energy availability, which can be reversed. And then the more extreme example is the red, which going towards the periphery. And again, you can see all of the different systems being affected. The only one which is slightly different is the mental health, and you can see that the arrow goes in both directions. So jumping just forward. So again, just here's the white arrow in the middle. I just made it a little bit bigger to make sure you can see it. And that the white arrow is the adaptable responses to low energy availability. And the red arrow is the problematic low energy availability. So, and again, this is the performance conceptual model. You can see again, it's very similar with the adaptable and problematic low energy availability. So we've talked about the energy mismatch. So the time course of low energy availability, there's acute mild periods of low energy availability shouldn't cause any problem. Problematic low energy availability of a excuse me, I'll just have to grab a drink of water. Low energy availability is what goes on to cause REDS. Short term can be days to weeks, medium can be weeks to months, and long term can be months to years. The time course can vary between male and female, and the severity and the duration of the dose of energy deficiency. So I'm just going to briefly mention, this is the life history theory. So this proposes that biological processes related to growth, health, activity, reproduction compete for a finite energy set of energy resources. And energy availability is the amount of energy intake left after the demands of exercise. So inadequate energy intake or increased energy use, basically one biological process may be affected, and you have trade-offs with others. So back to caveman days. So unfortunately, I couldn't find a skinny caveman, but it gives you the idea. So it's an evolutionary adaptive process to limit in times of biological survival. So in times of famine, etc., there was low energy availability. So everything down-regulated, and this was an adaptable response. In humans, we've evolved to be physically active, not to tolerate, and we can survive. The problem is our bodies don't necessarily tolerate high energy demands of those of an elite athlete. So, think of the marathon runner, or they can be training greater than 30 hours per week. And in these cases, they just don't eat enough to outweigh the amount that they're expending. So I've talked about the adaptable and problematic low energy availability, and I'll just expand on that a little bit. So adaptable is the benign form. So it's exposure to a reduction in energy availability. I've said it's benign, and it's mild and quickly reversible. So these may be things like monitored, mindful manipulation of body composition. It may be secondary to intense training or at the time of competition. And it may be associated with short-term benefits. The problematic energy availability, which is the red zone, is exposure that is greater and potentially persistent disruption of various body systems. It often presents with signs and symptoms representing a maladaptive response. And there's also other factors, such as moderating factors, which can amplify the disruption of health, well-being, and performance. And I'm not going to go too much into moderating factors, but these are things such as the individual athlete characteristics. It can be related to gender, age, their genetics, the environment, or behavior. It may vary according to the body system, and it can increase or decrease the risk of low energy availability. Now, I'm going to jump to overtraining syndrome for a little bit, and then I'll go back. And the reason I've given you a lot of information on low energy availability, but classically we've had a thing in sports medicine called overtraining syndrome. But interesting enough, they both have affect the hypothalamic pituitary adrenal axis, and there's a lot of overlapping symptoms. And there's a recent narrative review of people with overtraining syndrome, and they found that 18 of those 21 people actually showed indications of low energy availability and low carbohydrate availability. So this was potentially due to large increased training loads and failing to compensate for the energy expenditure. So maybe that what we've always called overtraining syndrome now is starting to be REDS. So think of athletes. They train to perform, and as their performance improves through increasing training loads, so this may be, and we think of exercise as the type, which is running, the frequency, intensity, and volume. So increased loads are tolerated by rest and recovery during periods of periodization. So training load is the overload and doing too much. And I'm just going to mention a couple of patients here. So I just talked about a dancer. I saw a dancer. She was dancing 7 hours per day, 5 days per week. And then on a Saturday morning, she was doing a class. But she loved to run too. So she'd go and do her 7-hour class of dance. Then in the afternoons, evenings, she'd go out for a light, long jog of about an hour just because she enjoyed running. And unfortunately, she probably tipped the balance a bit and got some stress injuries. The other person is, just think of the rugby player. Not the professional rugby player, but the one who's out there playing weekend sport. They're out there training on Tuesdays and Thursdays, and then they play on the weekends. But during the week, they often have very physical jobs, such as labourer, builder, etc. So they're spending a lot more energy than just their training load. This is a sort of graph of overtraining syndrome, and you can see down the middle horizontally, it goes for time, and on the blue squiggly line, it's sort of indicating what happens with training. So generally you get fatigued, as you can see the circle go under. As you recover, you respond and return to normal. And over time, you sort of, with various training, your baseline gets better, and you can tolerate more and more training with training periodization. The purple line is indicating what happens in an undertrained person or under-recovered person, and you can, as you get further and further from the baseline, you get a thing called overreaching, and then basically overtraining. But as I said, there's a big overlap with REDS here. So the diagnosis of overtraining and overreaching. Overtraining is a clinical diagnosis, and the problem is it's natural for us to feel tired. And we used to think, okay, if we're feeling tired and you're not recovering between sessions, it's general fatigue. And people say, okay, it's difficulty pushing yourself at training. You're having difficulty to train because you can't train as hard. and your previous performance is declining. You might have sore muscles more than usual, and you're sort of getting a bit fatigued and wanting to miss sessions, etc. So overreaching is a short-term effect. It's when you don't sufficiently recover from exercise workouts, and is usually from several hard days of hard training, and the effects usually reversed with rest. It sounds a little bit like adaptable low energy availability. Overtraining syndrome is where you have fatigue and underperformance in athletes. So it's previously been defined as a maladaptive response to excessive exercise without adequate rest, resulting in perturbations of multiple body systems, including neurological, endocrinological, immunological, and mood changes. So again, you can see it's very similar to low energy availability, and I think we're finding that I think a lot of the people who've been diagnosed with overtraining syndrome were actually low energy availability. You can see the general symptoms here: fatigue, low energy, sleep disturbances in psychology, and increased risk of illness, irregular periods, loss of appetite, diarrhea, constipation, again, are all associated with low energy availability in REDS. So I think the important thing these days, if we're going to diagnose anybody with overtraining syndrome, we really have to exclude REDS first. With recovery from overtraining, again, it takes weeks to months off. It can be a challenge psychologically. The stress of not training can be a problem. People exercise to clear their heads, but at the same time, if they're doing too much, they can't push themselves. So it can be a real psychological frustration. Treatment is rest, and not only rest from exercise, but it's making sure that they sleep well, you get good nutrition and mental wellness. And the return to training is gradual. When they start to feel renewed interest, they can train harder, and they listen to their body. So they might have a training log or a visual log. The important thing is adequate rest and gradual return, and also involvement of the dietitian, etc., which I'll jump at the end talking about REDS, but you'll see, I think very much a lot of what we called was overtraining is actually REDS. The AIS position statement, and I will not go into it now, but there's a few bits and pieces, and I think there's a lot of information that I'm presenting is from this. So I'm back to eating disorders and disordered eating. So with eating disorders, this is the mental illness diagnosed by the DSM-5 TR. Whereas disordered eating, we've got the same problems, but it doesn't meet the defined criteria. The prevalence of disordered eating in athletes is definitely higher levels of disordered eating and eating disorders compared to non-athletes. And athletes are more likely to have disordered eating rather than eating disorders. But it can affect any athlete, any sport, and any time. It varies with sports. There's higher risks in sports with pressure to lose weight or gain weight, and particularly in the aesthetic sports. Athletes with disordered eating don't have to be overweight. They may be they don't have to be underweight, overweight. They may be completely normal weight. So just jumping into some of the aesthetic sports where there's risk of decreased energy intake. These are usually because they're deliberately restricting their diet. The anti-gravity sports such as high jump, and then there's the weight limit sports. So again, they're decreasing intake to try and make weight. I'm just going to jump back one. I've sat there and been at sort of watching the jockeys weigh in, and it's just incredible how emaciated some of the jockeys look. They're thin, they look underweight, and very dehydrated as they're trying to sort of make sure that they've done all their saunas, etc., to try and make the weight for their horses. And then the high volume activities, which is your cycling, your distance running, and potentially distance swimming. Now, disordered eating, it's on a spectrum, and I've mentioned the spectrum before, but I'll just give it I'll show you briefly from this point of view. So it's on a spectrum through from optimized nutrition in the green to poor nutrition in the red. And it can be in different ways. It can be similar to eating disorders. It can be the restrictive eating, the skipping meals, the compulsive eating, irregular and flexible eating, vomiting, purging, and diet pills. The thing is low energy and disordered eating, there's often a close relationship. They can occur together, but also in isolation. The important thing is if you identify one of them, you should always look for the other. And just remember, they can be energy deficient and their weight is stable. So athletes can move across the spectrum during their career and also in different parts of their training cycle. The important thing is if there's a past history of a disordered eating and eating disorders, it may perpetuate ongoing underlying fueling of the body, and there's increased association with REDS. So identification is complex, and it's often a multidisciplinary team involving doctors, psychologists, and dietitians. And I'll talk about this a little bit more shortly. But I'll just mention a couple of special categories of athletes. So this is the para-athletes. We don't actually know what the prevalence of eating disorders is in para-athletes. There's concerns that they may be even higher risk than the able-bodied athletes. So this is a study of US para-athletes preparing for the Paralympic Games. They demonstrated 62% had tried to alter their weight or body composition. 32% had increasing scores on the EDE, which I'll mention shortly, and 44% of the female athletes reported menstrual dysfunction. And again, it's unknown whether the negative body image may be a factor leading to the disordered eating or eating disorders. It may be related to their disability, their athletic status, their competitive pressure, the training environment, or even a combination of the factors. So problematic low energy availability can appear bone health and bone-related injuries and the problem is with the para-athletes, there's already decreased or altered skeletal loading. So this may be because they're in a wheelchair, they're doing low impact sports, or they may have a unilateral amputee and it can affect their affected limb. There's also problems with central neurological injuries. It may result in changes in the HPG axis, and this can be independent of low energy availability. We know with people with spinal cord injuries that there's a significant loss in bone mineral density immediately post-injury. And therefore, there's a higher incidence of low bone mineral density and osteoporosis. The problem is we don't have baseline DEXAs for para-athletes. So I'm going to talk about prevention and identification of REDS. So ideally, we want to prevent it. And lots of this is going to be about education of athletes, coaches, parents. We need to teach them about REDS, the importance of optimal nutrition, and also about emotional well-being. The critical bit is recognizing, and I will talk about this a little bit more. The problem is when you have an elite athlete, such as they're under a support team. So when I looked after the dance school, it was great because there was a physio with the athletes all the time, and she saw them every day. And she often identified the athletes saying, oh, I'm concerned about X sort of thing. And if we were concerned about a athlete not making, who was losing too much weight, or we're concerned about things, we would be able to implement things straight away and cut down the amount of training they did, or trying to get them see a nutritionist and try and increase a little bit more. The problem is the recreational athlete comes in and doesn't have the support network that a professional person does. So drink water. This is from when she started. She basically felt that things had improved from the time when she first started her information, etc., on RED. She felt that there had been a bit more accepting of people for their shapes and sizes. They felt that people were starting to be accepted for the size they were rather than how skinny they were, and that some athletes were starting to be appreciated for their skill rather than their wardrobe. Now, I'm going to talk about the IOC REDS CAT2 assessment tool, and this is a really good thing, and you can download this off the internet really easily. And I'm just going to go through it. So, what is it? It's a clinical assessment tool, and you use it for athletes who are suspected of having low energy availability leading to REDS. This is based on the 2023 REDS consensus, and it's surpassed now the IOC REDS CAT1. So it's designed for athlete health and performance teams, for physicians, and for clinical evaluation and management of the athletes. So we've talked about this slide already, and I won't go into that again. And we've also talked about the sports performance conceptual models, so I'll jump ahead. So any athlete can develop REDS at any point in time, and there's a large differential diagnosis, and it can be really difficult diagnosing it. The detection is often self-reported, and it's important that we diagnose these people early. So if we can diagnose them early, we can intervene and hopefully help stop progression. We've talked about the risk athletes, the female, the weight sensitive, etc., and I won't go through this list at the moment. So this is the 3-step model of, so I'm going to go through these separately. So step 1 in the process is the screening tool. So it's a screening questionnaire. It has lower sensitivity and specificity, but it's inexpensive and it's easy to do. And I pretty much have used this many times in sports teams, etc. I give them this to fill out, and particularly the LEAF Q. So I'll talk about that first. There is now a LEAF. It's a LEAM, which is available, which is low energy availability in males. And there's many other questionnaires. And if you want more information, you can look these up on going to the site. So this is just a quick example of the LEAF Q. So it gathers personal data, age, height, weight, an injury history, a GI history, and menstrual dysfunction history, and the use of contraception. So this is just an example of questions. So do you have a normal menstruation? Yes, no. If yes, how long was your period? If yes, are your periods regular? And if yes, how many days do you bleed? So it's just giving us some information. But what you can use is that there's a scoring tool, and this gives us an indication. So it's a scoring tool of greater than or equal to 8 is considered to be risk of the female athlete triad. And we talk about triad because the LEAF Q was produced way before it was called called REDS, but it gives us the same information. Here's another example. And this is just scoring injuries. Have you had absence from your training or participation during the last year due to injury? And if yes, how many days absence from training or participation? So again, depending on what they answer, they get scored differently. But it's a good screening tool. Another screening tool is the EDE 17, and this is the gold standard for clinical interview for diagnosis of eating disorders. I don't use this, but it's something that's just being aware that is available. I would send them to a psychologist and nutritionist. So the EDE is a short form of the EDE 17. Again, this is just an example of what it looks like. So you score a scoring greater than 2.3 or greater than 1.6, and or clinical diagnosed DSM-5 TR is indicators of some sort of eating disorder. And this is just one example. Have you been deliberately trying to limit or the amount of food you eat to influence your shape or weight, whether or not you have succeeded? So these are just some of the questions that have been asked in the EDE. So we now jump to part 2. So part 2, this is a bit more sensitive, it's a bit more expensive, but it gives us some clear scoring, which allows easy, reliable implementation. So it breaks down a number of problems, and depending on whether it's a primary indicator. So some of the primary indicators, you get 2 points. So a primary amenorrhea in a female with age 15 with sexual characteristics, or by the age of 14 with no secondary sexual characteristics. You also can have prolonged secondary amenorrhea or low free testosterone. So these give 2 points. So these are the most severe. There's also less severe points, such as secondary amenorrhea, males with subclinical low free testosterone, subclinical or low total or free T3, history of bone stress injuries within the last or previous 2 years, or absence greater than 6 months. But I'll go through this in a second. There's also a few more primary indicators, such as bone mineral density less than 1, decrease in bone mineral density score prior to testing. And this, you can see on the left side, this is greater than 15, and there's also less than 15 years. So there's other indicators such as EDE, or a clinical diagnosis of DSM-5TR. So either of those would be classified as 1 point. Secondary indicators include oligomenorrhea, 1 bone stress injury, absence of for less than 6 months due to a bone stress injury, increases of total and cholesterol, and clinically diagnosed depression or anxiety. There's lots of potential indicators, but none of these actually get any scoring when doing this baseline, working out this information. So step 3, so what we're doing is we're using the information that we have taken from the history, and we're collectively putting it together and giving it a sort of traffic-like system. So using this with the clinical history and examination. And you might have a sports physician or a GP who's interested in this area. So it's a traffic-like system. So green, it's optimal health. Yellow is the caution zone, orange, the moderate, and red is the high-risk area. So we want to identify which area the athletes are in, and we want an accurate diagnosis so that we can treat these people. It applies to both the males and females, and they've used this successfully at the Norwegian Olympic Training Centre in 2012, and I think they're still using it. So just to make it a little bit bigger, so green is the optimal area that you want to be. So as you can see, yellow is mild, and the clinical criteria, depending on how many primary and secondary indicators there are, and treatment is indicated depending on what section you're in. So just jumping forward, so there's the most important thing when we try and sort this all out is it's a team approach. So it's not just one person. You need people involved. You need the dietitian involved. You need the psychologist involved. You may need an exercise physiologist. And I do think the physios who happen to be with teams all the time are just invaluable, because they see things which, particularly if they're sort of massaging them or treating them, they might have a general chat and they pick up things which possibly nobody else does. So this is the IOC CAT2 calculator tool, and this can be picked up from the IOC information sheet, but there is also a stratification calculator, which is here, and I'm just going to keep it very simple at the moment. So people can be categorized, and the problem is there's a lot more involved, and maybe the level of the athlete, the sport, the health. There can be conflicts of interests, and the intrinsic and extrinsic athlete pressures, depending, if you've got a top athlete who's about to compete, you may be wanting to get them through their competition and then deal with their disordered eating, etc., and trying to balance things. It's a tricky situation, but hopefully we get things before they get really bad. So back to the dancer. So we mentioned amenorrhea, sacral stress fractures, fifth metatarsal fractures, cuboid stress fracture, and depression. So when I put all this into the category, into things, you can see that she's got 3 primary factors: the primary amenorrhea, the subclinical low T3, and a sacral stress fracture. And she's got secondary characteristics as well: a bone mineral density less than 1, a fifth metatarsal fracture, a cuboid stress fracture, and history of depression. So if you look at all these things, you can jump down to treatment, and you'll see immediate treatment plus or minus hospitalization required by frequent monitoring, daily to monthly intervals depending on severity. Significant training and competition modification, and in major cases, removal from training and competition as indicated. So obviously this is going to have to be a multidisciplinary discussion and working out what is best for this person. I'll jump to another case. This is a 16-year-old female gymnast. She had primary amenorrhea with no secondary sexual characteristics, and she'd been diagnosed with the DSM-5 eating disorder. She also had depression and a fifth metatarsal fracture. So this put her in the orange zone. So treatment was close monitoring and follow-up, and some aspects of training and competition may need to be modified. So I'll give you one more example. So a 22-year-old male marathon runner who had subclinical low free or total testosterone, so in the lowest quartile, that had a femoral neck bone stress injury, and that had a third metatarsal fracture 18 months earlier. So again, jump them into the treatment, monitoring, and regular follow-up, full training and competition, and obviously getting over the treatment. So it's giving us a little bit of guidelines, not a lot, but of how to monitor and manage these people. So medical history is exactly the same as any medical history that you would take. The most important thing is you want to know about stress fractures and menstrual dysfunction. In females, obviously the age of menarche, you want to know lots of detail about the periods, which is going to be given to us through the leaf Q, and about their amenorrhea. And it's really useful getting the information about the pill, because obviously there's no point doing any hormonal profiling, etc., if they're taking the pill. In males, you want to know about their libido and loss of morning erections. And you also want to know about specific bone stress injuries, bone mineral density, calcium intake, vitamin D load. And this is a problem that I see particularly in skiers. Skiers will travel from the north hemisphere to the southern hemisphere, and they'll be moving back and forwards for the winter. So skiers actually often can be quite vitamin D deficiency, because it's uncommon for them to see summer. In their medical examination, you may need to look at the musculoskeletal areas of concern, such as bone stress, gynecological information, causes of amenorrhea, signs of eating disorders such as the lanuga, the erosion of tooth enamel, subconjunctival hemorrhages or swelling of the parotid glands, and also if they're potentially younger people, you may want to know their sexual maturation. This can be done through the Tanner classification, which I'm not getting into. I'm just mentioning that it exists, and it's a way of trying to figure out at what classification level that a athlete may be. So there's lots of investigations that can be done. So the most important thing is really just the basics. If they're a female, making sure they're not pregnant, you may need to do an ECG, and then hormone levels, etc. If there's concerns about polycystic ovary syndrome or hormonal variations. So there's also a number of biomarkers. Some of these would be used more as a secondary thing, and some of the things such as the appetite hormones, ghrelin is really only a research tool only. In the AIS guidelines, this is a really nice little chart of some of the changes that happen with the disordered eating, and it just shows you each component or whether it goes up or down depending on their levels. So assessment techniques. So we can do DEXAs, skin folds, ultrasound, and doing the pre-exercise screenings. The problem is when do we worry about doing body composition? So about a year ago, I had a 10-year-old dancer who came and saw me. She came in with her mum. She came in with some unrelated problems, with a bit of hip pain, and she'd been told that she was too fat by her ballet teacher and that she had to lose weight. And I was almost horrified to hear that a poor 10-year-old was told to lose weight. And her mum was being very sensible about it, and we had a big, long discussion. And I'll talk about this a little bit more. This is me as a 14-year-old swimmer. At that stage, I was doing probably 11 sessions a week, each of about 2 hours. And I remember being lined up every week on a Saturday morning. We had to line up and being weighed by the coach. And I can tell you that was a pretty tough thing. You know, everybody lined up being weighed, and if you were a little bit higher, you always felt very guilty. And just the last case study, this is a ex-gymnast who was training 24 hours per week. She was telling me of being weighed regularly and how the coaches used to pinch her to see how much fat she had. She had amenorrhea until she stopped gymnastics, and she recalls finishing late at night, often not feeling like she wanted to eat, and sometimes missing meals just because she was too tired at the end of the day. She mentioned that she'd, other girls would be crying in the toilet. She did it because she loved it. So the question is when should we be doing body composition? It's important to optimize health and athletic performance. We've already got athletes with internal and external pressures. It can, and of course, obviously it can lead to eating disorders. It's problematic, especially in the young athletes. And if we start measuring body composition, etc., potentially there's long-lasting psychological consequences. So pretty much it's recommended that for medical purposes, there should be only medical purposes only, they should be done less than 18, unless there's some sort of exceptional circumstance. So this is just from the 2023 IOC consensus. And so again, they're talking about so the athletic stage is on the left and the nutritional skills on the right. And really, you're looking at the very top. So it's the elite professional athletes at the advanced level. These are the ones that you should be concerned about sort of doing body composition, etc. on, not sort of the foundational or developing athletes. So this one's from the AIS guidelines and indications of when should we do a DEXA. So potentially 6 months of low energy availability or disordered eating. The important thing is we always look at the Z scores because these are age and sex matched. I always like to try and use the same machine if I ever have to do it. And look, it's very rare that I've ever had to do DEXAs on people. I usually encourage diet, exercise, those things as first line. So if we need to repeat it at risk intervals, potentially yearly, in adolescents, potentially at 6 months. The important thing, if there's low bone mineral density, a Z score is usually between -1 and -2 standard deviations. But you take it into the context of nutritional deficiencies, hypoestrogenism, stress fractures, and other clinical risk factors. The other thing that you have to think of is people are doing a lot of weight-bearing activities. You would expect their bone mineral density to actually be higher than non-athletes. So we've talked about the treatment approach. It's multidisciplinary. It's also important to engage the family of the athlete, the coaches, staff, etc. And it's also good to have one person that's communicating with everybody. We need the athlete agreement, and it's also important to have patient confidentiality. So each sports body often has some sort of guidelines to identify disordered eating and eating disorders. Our treatment is really aiming to have safe participation. Assessments can be medical, nutritional, and psychological, and we need regular review. So training modifications can be cutting down, but it very much is going to be dependent on the athlete and their compliance, and it's pretty rare that we have to completely exclude. The dietitian is important, as I've discussed, increasing their diet, decreasing their exercise, increasing macro and micronutrients. The problems is intake may be difficult with athletes to accept and implement, and the dose of low energy availability, it may be influence the time of recovery. So we can't be exactly know how long it's going to take with optimal nutrition for somebody to resume menses, etc. Supplementation is always the first line. And again, the dietitian is the best source at looking at supplementation, particularly with food sources, not going directly to supplements, etc. With vitamin D, the cutoff is controversial, but often the vitamin D levels get lower over winter and they get higher over summer. And one of the recommendations, again from the AIS guidelines, was 50,000 units weekly for 8 weeks, and then a maintenance of 1,500 to 2,000 units per day. Psychological assessments from psychologists. The important thing is, look, I'm involved with the Brumbies women, and we have a player welfare officer, and she's invaluable. And she's not involved specifically with my side of things, but she's involved with the athlete, and she's dealing with the athlete as a person. She's helping with them with their stresses of home life. It could be family, work. She's helping with finances, as well as all the medical expectations and trying to negotiate that with them. So I think having somebody like that is just great. Psychological assessments, we've mostly covered all this, but it's making sure that there's no underlying concerns such as suicidal ideation, and identification of athletes wanting to change, their challenges, and their readiness to change. And we've talked about the useful things such as the EDE, There's also the mini international neuropsychiatric interview. So the clinical assessment tools we can use, and we're having to use them in our graduated return to play. So in summary, the underlying cause is low energy availability and low carbohydrate availability. It's not a triad, it's a syndrome. It affects male and females, and there's a huge crossover with overtraining syndrome, and there's a huge number of multiple screening tools that we can use. And I hope everybody's still awake.
Yeah, that was really interesting. I'm just thinking about the Olympics now, kind of look at the athletes in a bit of a different way. I imagine that for people to stop training when they've been training for so many hours a day is really hard for them, because they've got to fill that time in that they used to fill in with training. So the psychological adjustment would be huge. So that being said, there's a couple of questions if we've got time for them, Karen. So the first question is, interesting that REDS in men causes low serum testosterone. In bodybuilders who are using testosterone supplements, still potentially having body dysmorphia, are they in fact treating their REDS? Bones are probably fine, but still low energy availability and psychological parts of the syndrome.
I can't answer that question. I think there's too many factors involved with testosterone. Testosterone is a completely different field on its own, and they probably are they're treating a component of their REDS, but I can't tell you any more than that. I just wouldn't know, because they'd still be potentially energy deficient. It's just the only component your test would be treating would be testosterone. And in any sport, testosterone's a no-no, except for the bodybuilders.
Yeah. And the second question is, do you have any concerns about the new variations in sex characteristics laws in the ACT that will involve authority from a tribunal to give HRT to girls with REDS?
I haven't thought about that one either. I mean, to me, I would be talking to an endocrinologist. That's sort of getting out of my my stuff. So I anything that I'm concerned about, I talk to an endocrinologist.
Right. Yep. They're important in this space as well. We have another question. What would be the identifying features to look for REDS in peri or postmenopausal women?
Okay, so I think the most important thing is they develop stress fractures. Obviously the size of the person is an indicator. I do see quite a few, peri and postmenopausal women, and I think, can somebody stop this dog scratching? I think the main thing it's just being aware of it. The first thing, the period is only a surrogate marker. If they have got any bone stress injuries, or you're concerned that they're underweight, it's really sitting down and having a chat about their diet history and say, oh, look, so, what do you have? What's your average day intake, and what do you have after your exercise? And I always sit down and say, okay, what do you have for breakfast? What do you have for lunch? What do you have for dinner? And just get a general idea of what they eat each day, and then what do you have before training or after training. And in a couple of minutes, you've got a pretty good idea of what they're eating. And often you can pick that, oh, they're actually not having enough carbohydrates, or no, they're on a high protein diet, etc. So I think you can get a general idea by just a quick overview of what they're eating, as well as if they've come in with a bone stress injury. My alert factors go straight up going, look, is there a bone stress injury? And if they're sort of perimenopausal or postmenopausal, I'd be very early on in getting some sort of bone density to check what their readings are.
Mm. Yeah, I think for GPs, like you kind of see them a little bit filtered, but for GPs, we see them in the rough, and it's the bone stress injury, or the woman trying to get pregnant, or the funny blood tests that don't make sense is our first kind of hint that someone might have something going on.
Yep.
Yeah, that was really very, very interesting. And, I wrote down lots of questions, so I won't bore everyone else with them. It's 8:30, so we might wind it up there. So thank you so much, Karen. We can see how much work and effort you put into presenting that, and it was really engaging. I'll just let everyone know that it will be on the Capital Health Network YouTube page in about a month. So if you want to have a look at it again, or if you didn't catch all of it, it should be there. We'll send you out the evaluation surveys very shortly, and please fill them in, and we'll send you out a certificate of attendance after the event, and you can report your 1.5 hours of educational activity to your CPD home. Yeah, we'll wrap it up now. Thank you so much, Karen.